So thank you so much for being here today. Thank you, Mr. Hines, for introducing me. I do want to introduce myself just quickly. My name is Donnell Ivy, and as it was mentioned, I went to medical school in the 1990s. But I'm also an individual that lives with sickle cell disease hemoglobin SS. And I usually like to start my talks with saying that when I was born in the early 1970s, the average life expectancy for a person with sickle cell disease in the US was 14 years. I stand here today before you, and in a few more weeks, I'll be 55 years old. And I started Hydroxyurea shortly after I met Dr. Hines today. But unfortunately, we know that we have to do a better job at getting hydroxyurea and other therapies to the sickle cell population, to the sickle cell patients. So we want to start that conversation now with this next session on hydroxyurea, transfusion, and beyond, treatment decisions in sickle cell disease. So I'd like to start by introducing our panelists, and I'm going to do all three, and then they'll come up for their talks. So our first speaker is going to be Dr. Robert Klaassen, and he is a pediatric hematologist-oncologist. He's the hematology physician lead for the Division of Hematology Oncology at the Children's Hospital of Eastern Ontario and full professor at the University of Ottawa. A long-standing advocate for patients with sickle cell disease, he is a founding member of the Canadian Hemoglobinopathies Association, or CAN-HEM, and has co-chaired 3 sickle cell disease conferences, including Canada's first National Sickle Cell Conference. He also advocated for the inclusion of hemoglobinopathies in Ontario's expanded newborn screening program. Our second speaker will be Dr. Robert Johnson, who earned his PhD in neuroscience from Cornell University and is a medical affairs leader with more than 20 years of experience across rare diseases, hematology, oncology, translational research, and scientific education. As field medical lead for medical strategies, engagement, and disease state education initiatives across rare disease, hematological, and immunological disease disorders. And our last speaker, but definitely not least, is Daniel Adesina. Daniel was born and raised in Nigeria, and his experiences with sickle cell disease have shaped his understanding of the importance of informed, patient-centered care. After moving to Canada in 2017, Daniel has continued to manage his health while learning to navigate a healthcare system. He now shares his lived experience to help healthcare professionals better understand the patient perspective and also serves as a mentor in SCAGO's Youth Empowerment Program. Thank you so much.
Hello, it's great to be here and great to see such a good turnout. And I think one of the things I just want to warn people a little bit in that you heard about the drive from the United States to here. I flew from Ottawa, and Air Canada in its wisdom had a mechanical problem, so I had supposed to be doing the 7 o'clock flight. I took the 5 a.m. flight, so I had to get up at 3 o'clock in the morning. So if I seem a little dazed, that's why. Apologize ahead of time. But no, I'm very excited about the talk we're going to give today. The one disclosure I think is an important one to this talk is that I have done consulting for Vertex Pharmaceuticals, and I will be talking about that during my talk, so just to keep that in mind. So I'm going to talk just briefly about what is sickle cell disease and talk about treatment options, and then talk about the potential cures that are available, and then a quick conclusion. So what is sickle cell disease? And you had a far more detailed discussion, and our previous speaker did a great job, but just a reminder, so red blood cells are shaped like donuts. I always tell them it's like donuts, but there's no hole right through the middle. They look like donuts. And with sickle cell disease, they get transformed. Because of a single change in an amino acid, they can transform into these sickle-shaped cells. That's the name of the illness. And this is, just to show that I'm not making this up, this is an actual, looking under the microscope, you can see the difference between here's the donuts right here, and then here's the sickled cell. So you can going back to what the previous speaker was talking about, is these, you can see these are nice and flexible, and they've got a lot more flexibility to it, whereas this sickled cell is very rigid and inflexible. So this is a great slide from back in 2008, but it's still very relevant. We often think of sickle cell disease as of this blocking the blood flow part of it, causing vaso-occlusion, so the vaso-occlusive crises, which basically you're stopping the blood flow through a small part of the body, which causes trouble. But there's also another component to it, which is this hemolysis, and that's what we've been hearing about, is that the red blood cell breaks down, and that causes trouble as well. So there's kind of these two components, this blockage component and the red blood cell breakdown component. So it's kind of important to think about when you think about the problems that you can see with sickle cell disease. My colleague in Ottawa, Dr. Alan Tinmouth, has this very nice slide, and I think it really is helpful when you think about treatment for sickle cell disease. There's the disease-modifying treatments, with hydroxyurea being the most important one, simple blood transfusion, and then a replacement therapy, which we're going to talk more about later, which is called red blood cell exchange, and then finally curative therapy, stem cell transplant, and gene therapy, we're going to talk briefly about. So hydroxyurea. So this drug has been around, it was made in 1869. So I know some patients say to me, oh, you're trying to get me to take this drug because I'm going to make money out of it or something. Nobody's making money out of hydroxyurea. It's been around for a long time. And the good news about that is that it's overall relatively cheap because of that. The bad news is that there's no pharmaceutical company pushing to kind of advance it and make it more palatable, so we're stuck with what we have. But the way it works is that it stimulates the production of fetal hemoglobin. So I have to tell families that we're basically trying to bring you back to the womb. We're trying to get your hemoglobin to go backwards in time, because when you're inside your mother and when you're newly born, there was no problems with sickle cell disease because this fetal hemoglobin basically protected you from the problems. So, and just to show you, like, this is what happens. So this is what the blood smear looks like before you start hydroxyurea. You can see those rigid sickled cells here throughout the blood smear. Then you start the hydroxyurea, you can see it becomes less. And then when you hit the maximally tolerated dose of the hydroxyurea, the sickled cells are basically gone. So it's a very effective treatment, and you can look at it through the microscope. One of my colleagues, Russell Ware, he said you should have a microscope in the lab and have all your patients look down the microscope. We unfortunately don't do that, but I think it would be very helpful because you can see how well it works. So this is a study that involved babies, 9 months old, randomized 100 to hydroxyurea, 100 to a sugar pill, and I want to point out that this was not, they didn't push, because it was just starting, they didn't push to the maximum tolerated dose. But you can see, so the placebo is the blue line, and then the hydroxyurea is the red line. And each one of these little ticks up here means that one patient had whatever the issue is. So had a chest crisis, so every little tick means that a patient had a chest crisis. And you can see that basically, there was double the number of chest crises in the placebo versus the hydroxyurea. There was more pain, more of this hand swelling, this dactylitis it's called, and more needing transfusion. And I think the impact is even better when you get to maximum tolerated dose. But you can see these were all statistically significant. There was definitely improvement related to hydroxyurea. And this is in babies, so starting at 9 months of age. So very young age, you can see the benefits. This was a really nice study done in Brazil where they looked at 1,700 children. And sorry, I'm a pediatrician, so I'm a bit biased. I do tend to talk about children, but most of it applies very much to adults as well. Is that out of the 1,700 children, this was back in 2013, so there wasn't as widespread use of hydroxyurea at that time. But you can see 267 of them were on hydroxyurea for various reasons. So you could argue that they're actually the more severely affected patients because they were started on the hydroxyurea. But actually, when they followed them, there was the ones on the hydroxyurea had a much lower death rate. So 1% if you're on the hydroxyurea versus 5% if you're not on hydroxyurea. And there was less infections, less chest crisis, less hospitalizations, and less emergency visits. And the hemoglobin was increased. So this was a real world, not a clinical trial where you kind of select the patients. This was what they found in Brazil. So clear benefit to hydroxyurea. So unfortunately, hydroxyurea doesn't work in all patients. It works in the majority of patients, but it doesn't work in 100% of patients. Or it doesn't have as good an effect as you want. So the next step up that we do in that, as I was showing the stage you go through, is called red blood cell exchange. So what do we do with red blood cell exchange? We're replacing sickle blood with non-sickle blood. And we're trying to aim for a hemoglobin, sickle hemoglobin of less than 30% or 35%. And where does that come from? We know that people who are carriers of, so many of you in the room are carriers of sickle cell disease. You have your hemoglobin S percentage is roughly 35%. And we know that carriers don't have major complications from sickle cell disease. In fact, there's a blood article that came out like yesterday looking at carriers of sickle cell disease. They looked at, in the UK, about 100,000 people and compared them to ones who are carriers and not carriers, and there was no increased mortality if you're sickle cell carrier. So good news is, if you're a carrier, you do not have an increased risk of dying because you're a carrier. So we're trying to take people with sickle cell disease and make them into carriers, is what we do with an exchange. And this was I'm missing part of this. Okay, so there's supposed to be a table there. You'll have to imagine the table. Or maybe it's in white, and that's why it didn't show up. But anyways, it was a randomized study of basically 200. They seem to love 200 when they're doing studies, because this is also is 200, and of children who had what's called a silent stroke. It's called a silent stroke, but it's not necessary. But there's no overt signs of a stroke. But basically, they saw it on a scan that they had a stroke. So half of them got exchange transfusions, and half of them were observed. And the ones who got the exchange transfusions, only one had a stroke, whereas 7 had a stroke if they were just observed. So that's just kind of showing you the benefit. There's lots of other benefits from exchange transfusion, but that was just kind of one example to show you. Next, and the one curative therapy that's been around for a long time is bone marrow transplant. So I'm just going to quick talk about bone marrow transplant. So you have the recipient, which in our setting is a patient with sickle cell disease. And then you have a healthy donor, which in general we pick brothers or sisters who are what's called HLA matched. So they're matched for the patient with sickle cell disease. And then so what happens is you collect cells. So basically that's the hip bone. So you take needles and you put it in the hip bone, and you've done these collections, and basically the person's sedated. So if you're going to be a donor, don't worry, you're asleep. And you're basically just putting needles one after the other all along the hip bone, collecting the cells, and you collect it in a bag, and your hand gets very sore when you're pulling out the bone marrow, but that's just kind of a very primitive way. You're just pulling these cells out of the bone marrow. And if you're a donor, don't worry, those cells get replaced. They come back fairly quickly, so it's not a long-term problem. Then I think the important thing to know is that the recipient gets anti-cancer drugs. So they get high doses of chemotherapy and sometimes radiation, but for the most part, it's high doses of chemotherapy. So it's not a benign thing. So people think of, I want a bone marrow transplant, but there is it is a fairly major ordeal because you have to wipe out all the sickle-producing cells. If you just put the donor cells in without doing that, they would get destroyed by the body's immune system. So you have to wipe out. It's kind of Roundup where you clear things, and then you're putting the seeds in, and they grow. and then it gets injected into the recipient. So that's what a bone marrow transplant is. Like I say, for the most part, we tend to limit it to families who have a matched brother or sister because the risk is lower, and I'll talk a little bit more about that. So focus on the B one down here. So this is what's called overall survival. And so this tells you when they had the bone marrow transplant, each little tick down is unfortunately somebody who died after the transplant. So there is risks with this transplant. But you can see this is over 10 years that the survival is, and this is a large study published in 2017, so hopefully we're potentially doing better than this, but you can see that it's well over 90% and roughly 95% overall survival with a bone marrow transplant. Most of these patients were for matched brothers or sisters. And then the flip side, the one other downside of bone marrow transplant is this thing here called GVHD, which is graft versus host disease. So one of the problems is you can cure sickle cell disease, but unfortunately, occasionally you can get a problem where that graft comes in, looks around and says, hey, this isn't the right, I'm not in the right spot, and it starts attacking the host. So this new bone marrow goes in and starts attacking the host and causing a condition called graft versus host disease, which can be quite significant and very debilitating. So you could potentially change one disease for another disease. And this is probably the main reason why we try to limit it to matched siblings, because the risk of that graft versus host disease is quite low when you have a matched sibling, whereas if you start using parents or unrelated donors, this goes up, this graft versus host disease. But you can see this is children in the red, and it's about 10% can get it, whereas adults, the risk goes higher, it's up to 20%, which is why children tend to do better with bone marrow transplant in general. And then gene therapy. So there's 4 different kinds of gene therapy. You can see this one, A, is basically what's called gene editing. Basically, you snip a part of the gene and you put the new gene in. And the classic one is CRISPR-Cas9. And then there's other ones called gene correction. And I'm not going to go too much into that because we don't have that readily available. There's gene silencing and then gene addition by a viral vector. And this has actually been used in sickle cell disease as well, but we don't have availability in Canada. The only one we really have potentially have available is the A one. So I'm going to focus on that, the gene editing. So this is really exciting results. These are fantastic results, and this was published back in 2024 in the New England Journal of Medicine, which is kind of the journal for published results. So you can see what it is. These little blue diamonds are when a patient is having a pain crisis, a significant pain crisis. So you can see all the blue diamonds that are happening in all these patients leading up to when they had the gene therapy. And it's just dramatic. Like the gene therapy happens here, and then virtually all the patients, they have no more of those blue diamonds, so they don't have any pain crisis. It's quite, and actually I would not have expected this. I would have thought it would take time. You'd still be having pain crisis for a while afterwards, but it's actually very dramatic how the pain just goes away. And you can see how there's still there's 2 or 3 patients who still have some issues, but the vast majority of patients, over 90% of them, had a dramatic improvement with gene therapy. So it's very exciting. Okay, it's very exciting. It says, why aren't we doing this? And I'm going to talk a little bit about this. So Health Canada approved gene therapy in 2024 in Canada, and then this thing called the Canadian Drug Agency, CDA, reviewed the data and made their own recommendation. And I wanted to show the data on this. Is January 2025. So it's 18 months, more than 18 months ago. They said reimbursement recommendation for Casgevy, and I want to point out again, I've done some consulting work for Vertex, so I am a bit conflicted on this. This is approved final recommendation reimbursed with conditions for patients 12 years of age and older with sickle cell disease. And this is what is the reimbursement recommendations. Recommends that Casgevy be reimbursed by public drug plans for the treatment of sickle cell disease with VOC if certain conditions are met. So I just want to say there's not been a single patient in Canada who's had gene therapy outside of a clinical trial yet, even though this recommendation was 18 months ago. So this is where you guys have got to get out there and start bugging all the politicians you know to say, why is it taking so long? And this is because the provincial governments are balking at the cost. So I think this is where you guys have got to get active on this. Just quickly, I'm going to talk a bit about mortality and sickle cell disease. And this is, when I was introduced, you kind of brought this up. This is back in 1979. You can see that one of the problems was there was a lot of children who died of sickle cell disease, and in a very young age, under the age of 5. And the main reason for that was death from infections. Good news is this was in 2006, dramatic improvement in the mortality rate in children, and that's entirely from prophylactic use of amoxicillin, penicillin, amoxicillin, and vaccination rates. So very important. Vaccines are crucial, especially in sickle cell disease. So really important. You can see the dramatic. We went from 15% of children dying, and this is in North America, versus much less than that. And then overall, you can see there's a general shift in older adults. It used to be the median was in the 30s. It moved into the 40s, and that was, again, with the treatments with hydroxyurea. And then you can see, again, you can see that the survival rate, and this is the data, again, in the 60s and 70s, was around 15 years was the median survival. And then you can see the dramatic improvement with all the various treatments that came along. And I think this is a really nice one. You can see this is the United States, where the median survival is 75, not as good as Canada, but anyways. And you can see, you looked at them, this is without sickle cell disease, and you can see the dip here with COVID, and then back up, so it's around 75. Whereas with sickle cell disease, it was in 2008, it was the median survival was 50, and then it moved up to 60, so a 10-year gain in the median survival. So dramatically, and this is in a very short period of time. So this is really quite impressive. And this is just another way of looking at it. You can see here 2016, this was published in 2024, that there's less than 40% of the patients died over the age of 60, but now it's more than 50%. Basically, the median survival is improving and improving. So I think I just kind of wanted to highlight that there's been a dramatic improvement in survival in sickle cell disease in a very short period of time. And I think especially with the new curative therapies coming available, that's going to improve even more so. So just in conclusion, and look at that, I'm right on schedule. Good for me. So we know that sickle cell disease can cause significant organ damage and shortened lifespan. Organ damage can be prevented by use of hydroxyurea and red cell transfusion. We talked about that. Bone marrow transplant, especially if you have matched sibling, can be curative. And gene therapy has a significant potential if we can get our politicians to actually agree to pay for it. And there's been a dramatic improvement in the median lifespan of patients with sickle cell disease, and it's approaching the healthy population. So I think that's that. I'll stop.
So we're going to hold questions until all three speakers had gone, but please write down your question, keep it in mind so that we can come back to you after all of the speakers.
That is not me. Oh, yeah. That is me. Thank you. How you guys doing? My name is Robert Johnson. I am the field medical lead for Chiesi Global Rare Diseases. Just a little background on who I am and why I'm focusing on this particular topic. I've been with Chiesi for about 6 years, working in the context of iron overload, transfusion-related iron overload. In the last 3 to 4 years, specifically, I've been working in the realm of sickle cell disease as it relates to iron overload. And one of the things that keeps coming to my attention, and as I speak to physicians and patients, is the lack of understanding of the importance of iron overload as it pertains to sickle cell disease. How to treat it, how to monitor it, and really how it fits into the treatment paradigm for a patient. But interestingly enough, there have been two areas. So as it pertains to the patient, a lot of patients don't truly understand the impact their transfusions are having them long-term as it pertains to iron. And it's only when it becomes a significant issue, so as far as end organ damage, where iron overload is taken seriously, whether it be from a knowledge perspective or from a treatment perspective. The other is from a physician's standpoint, where physicians are well aware of iron overload and the potential for iron overload with transfused patients. But because of a lack of communication or understanding, a large number of physicians really don't understand how much transfusions their patients are really getting and how that's implicated in their long-term iron burden. So I think, and part of the reason from a physician's standpoint, and this is borne out to be true, is that in the realm of the many, many complications that are involved in sickle cell disease and sickle cell patient care, iron does not fit into, is not high on that list, mainly because iron overload is what we call a silent killer. There are no symptoms. You never know you have iron overload until you monitor and detect it, or it results in an end organ damage. And by that time, it's not now your iron overload that becomes your primary issue. It's dealing with the damage that this iron has done. So I think it's important to keep this in mind when as a physician as well as a patient, that every time you're getting these transfusions, you're introducing iron into your body. This iron does not leave. It stays there. So whether you get a transfusion all at once or over the course of your lifetime, every transfusion you're getting is introducing iron into your body that is not being removed. And the only way it's going to be removed is by actively using what is called chelation therapy. I'm going to go over all of this, but I think it's important for me to say this up front so you truly get the impact and truly understand the importance of the information I'll be giving you now and how you could potentially implement it in your care, whether it be as a physician or as a patient. So, as it's been said before, blood transfusions actually are an established treatment methodology for certain types of complications as it pertains to sickle cell disease. Blood transfusions introduce, as I said, iron into the system, and it can be a significant amount of iron. This iron, if left in the body, actually can manifest itself by causing end organ damage, such as liver disease, cardiomyopathy, and an increase in premature death. So again, it's critically important to know how much iron is in the body, as well as being able to treat it early to remove it so that this toxicity is not accumulating over time. So what are the goals of transfusion? One is the correction of anemia, reduction of HbS. So as it was said earlier, the amount of HbS or sickle hemoglobin is critically important as to all the complications that will occur. So one of the things transfusions does is by introducing normal red blood cells, it effectively dilutes out the HbS or sickle hemoglobin for normal hemoglobin. And that way you can get your ratio to be back more normal than sickle. Effectively, what you want is you want an HbS or sickle hemoglobin level to be between 30 and 40%. The lower that percentage is, the better it is for that patient, the less chance they are of having these complications due to vaso-occlusive crisis and anything else that's associated with having a high sickle concentration. It also suppresses the circulation of the sickle hemoglobin. So by introducing red blood cells into the system, normal red blood cells in the system, you actually can suppress the endogenous or the patient-made hemoglobin. We all know that when they're making hemoglobin that is HbS. So effectively what you're doing is you're decreasing the rate of that hemoglobin being produced by these patients. We reduce hemolysis, as well as we increase the oxygen capacity. This is specifically due to the fact that you're introducing normal hemoglobin into the system, which has a greater oxygen capacity. Therefore, you're also increasing the oxygen that is flowed and utilized by the body. The other thing it's important to say is that the target hemoglobin that one is potentially looking for in the context of transfusion for sickle cell patients is a hemoglobin level of 10. Now, I will say this in advance. Most physicians who are not specifically involved and really understand sickle cell disease, they don't understand that a target hemoglobin for sickle cell disease is 10. A large number of them are unaware that sickle cell patients actually have a significantly decreased hemoglobin level at baseline state. So when they are looking at a sickle cell warrior, and they don't know that they're a sickle cell warrior, they're looking at a different normal hemoglobin level. They're going to be looking at a hemoglobin level of around 14 as normal. So it's very important that if you are not talking to someone who's familiar with sickle cell disease, that they're aware of your state, and hopefully you know what your baseline hemoglobin level is, so you can convey that to the treating physician, because that number is going to have a large part to do with whether you're getting transfused or not. And if they're using if they don't understand that your number is normally low, they may be transfusing you for completely inappropriate reasons. So I think that is a key piece that I'd like to convey to all the warriors, caregivers, and even to the hematologists and so forth that are out there, that your patients really should have an idea of what that baseline number is. So it's already kind of gone over the types of transfusion. There are two. One is simple transfusion. It's just what it says. Basically, you're just introducing normal hemoglobin to the patient. This does not take into account the fact that they are making hemoglobin, that it's sitting there, or that they already have hemoglobin. So you are adding hemoglobin to the system. Every time you add hemoglobin, you're adding iron. So in doing so, you are now contributing to the increase of iron in that patient. We will get into the specifics of that in a minute, but just understand that's what simple transfusions do. It adds blood to a system. Exchange transfusion works a little bit differently. Effectively, what it does, its goal is to maintain the hemoglobin level that the person is on, but it exchanges the sickle hemoglobin for normal. So while you're basically getting the same impact, which is decreasing the amount of sickle hemoglobin within the patient, you're doing so without having to add red blood cells, therefore adding iron into the system. And transfusions can be done in two ways. There's acute and chronic transfusions. Acute is for acute complications, chronic for chronic complications. These are some of the symptoms that transfusions are used for. As you can see, this is for acute transfusions. There are very specific indications where transfusions are required. It is not just used as a cure-all for a patient who's having a crisis or having pain in the acute setting. However, when it comes to chronic transfusions are usually done on a scheduled basis, usually within every 4 to 6 weeks. They're scheduled, therefore everybody knows that they're getting transfused. There's an understanding of the importance of iron regulation in these particular cases. And again, very prescribed cases where you would use transfusion in this setting. There are some complications that do come with transfusion: alloimmunization, delayed hemolytic reaction, transfusion, infections, and iron overload, which is what we'll be talking about specifically. So just a really brief, give you an idea of how iron is utilized in the body. All iron is introduced to the body through your diet. It's then bound to transferrin. It's this bound transferrin iron that actually gets utilized by your body. Bound to transferrin, it's non-toxic, it doesn't cause issues. It's when this iron is free and not bound to transferrin where it becomes toxic and actually can cause that damage. So that non-transferrin bound iron, or NTBI, actually easily incorporates itself into organ systems. Predominantly, you'll find iron overload occurs in the heart, in the liver, and in the endocrine system. Each one absorbs iron at a different rate, so it's important to know that and understand that you really have to test all the systems to be able to truly make sure that a patient isn't iron overloaded. So, when we're introducing a transfusion, like I said, we are actually also introducing iron. In fact, 2 packs of red blood cell units contains as much iron as a person would get out of a year's worth of diet if it's introduced normally. It gives you an idea of how much iron you're actually introducing into the body when you're giving a transfusion. It is estimated that between 10 to 20 transfusions is enough for a patient to become iron overloaded. So again, this is why it's critically important to know how many transfusions you've had over the course of your lifetime. This iron does not leave unless you remove it. So that 10 to 20 is critically important over a lifetime. So what I'd like to go through is how you're going to know you're iron overloaded or not. There are three predominant ways. The first, easiest way is a blood test called a serum ferritin test. It is easy to do. Most physicians can do it. It's inexpensive. The one thing about serum ferritin test is that while it is easy, it is not the most accurate test. So it is important that one singular serum ferritin test is not really enough to let you know if you're iron overloaded unless it's significantly high. But it's really the accumulation of serum ferritin. So it's the trend that matters. The next is what's called the liver iron concentration, LIC. This is an MRI-based assessment. It specifically looks at iron in the liver. It is a very accurate test for iron overload. It is expensive, but relative to a serum ferritin test, but it is actually one of the best ways to be able to monitor and look at liver iron content. The next is called the cardiac T2, which does the same thing. It's an MRI-based looking at the heart. I will say that in the context of sickle cell disease, liver iron overload is more prominent than cardiac. Cardiac actually is somewhat rare in the context of sickle cell disease, but it is important to get at least one cardiac iron test done just to make sure that it has not occurred, iron overload has not occurred in the cardiac system. So when it comes to monitoring, the recommendation for monitoring, serum ferritin, it's every 1 to 3 months, again, highly dependent on how often you're getting transfused. These are really are recommended for people on chronic transfusion, but I think even those who are getting episodic transfusion still should get monitored for iron periodically, again, just to make sure that everything is fine, especially if they know they've had transfusions between monitoring sessions. LIC should be done every 1 to 2 years. An LIC over 7 is the point at which you are considered iron overloaded and need to be treated as such. Below that, it's really just about monitoring and knowing the level. Cardiac iron, it would be a T2 star value of less than 20 is when you start to worry about having iron overload in the heart, and below 10, for sure, you are iron overloaded. So the only way to remove this excess iron from the body is called chelation therapy. And effectively, it's using a molecule to bind to that free iron and to remove it from the system. It's either removed by feces or urine. Chelation therapy is administered there are 3 current chelation options. I will go over them in a second, but it's important to know that chelation as a therapy takes time. It took time for you to get iron overloaded. It is going to take equal time for you to remove that iron. Therefore, it's important for people on chelation therapy to realize that it can take months to years for the chelation therapy to actually show up as decrease in value. The fact that the values don't change doesn't necessarily mean the chelation therapy isn't working. Adherence is the key as it comes to chelation therapy. The more adherent that patient is, the more readily they will get rid of that iron, the better their chances are to get those numbers to reduce over time. So the objective of chelation therapy is to, 1, remove the excess iron, is to reduce the risk of organ damage, decrease the risk of permanent death, and to balance the iron intake from the blood transfusion. So basically to remove that excess iron that you put in due to transfusion. The values that you're looking at when you're talking about when you need chelation therapy is for LIC is for an LIC greater than 7, serum ferritin over 1,000, and a cardiac T2 star can be between about 20. It's also important, again, if you know how many transfusions you use, you can use that as a surrogate to the potential that maybe you should be on chelation therapy or not. But again, it's still important to get the official monitoring to be done and get an official value. There are 3 chelators. There's deferoxamine, which has been around the longest. This is done either subcutaneously or intravenously. It's done daily over 6 to 8 hour infusion times. So it's a very good chelator, but very cumbersome from a patient standpoint. But it is, in fact, still used. It does have some side effects. Ocular and auditory would be the 2 main ones that patients have seen when under this therapy. There's deferoxamine, which is an oral medication. It's taken once a day. It too has some adverse events, mostly GI, and anybody on it also should be monitored when it comes to kidney function because it does have an impact on the kidneys. Therefore, again, when a person's on it, that's the kind of additional monitoring that needs to be had. And there's deferoprone, which again is another orally administered medication. It's tablet and liquid form. It is taken twice a day. It too, because it's oral, it has GI issues, as well as an incidence has been known, and it actually is a black box warning for agranulocytosis and neutropenia. However, so that also has to be taken into account, and there's specific monitoring that has to be done for patients on deferoprone to make sure that the agranulocyte neutropenia does not occur and that it's taken care of if it does. So with that, I am officially done. I thank you guys for your attention.
How's everybody doing today? Good. I want to say apologies. For the slight delay in my introduction. I went to the bathroom to do jumping jacks to get rid of the nerves. So, yeah. So, thank you as well to the healthcare professionals with the amazing information that they were able to give today. I'm a pair or individual with sickle cell disease. I'm going to be mainly speaking to the healthcare professionals today, kind of more on my experiences and a lot of the experiences people like myself face in moments like that. No disclosures. Introduction. I was born and raised, my name is Daniel, by the way. I was born and raised in Nigeria, where I grew up living with sickle cell disease. For years, I kept it private. It was something I honestly wasn't very comfortable talking about. In fact, me 5 years ago would not be doing this today. You would have to tie me up and put me on here to talk about it. But yeah, I was scared it would make me seem weak. I was scared I would be the black sheep in school. I was scared I'd have to have a lot of awkward conversations in front of people, and I frankly did not want to do that. There was a lot of stigma, especially back home in Nigeria. I moved to Canada in 2017, and I've spent most of my adult life navigating the disease alongside my healthcare team. They're very amazing, by the way. If I could shout them out by name, I would. Today, I volunteer with SCAGO, and I want to share what shared decision-making has looked like for me throughout my process within the healthcare system here in Canada. Treatment. Over the years, my treatment has included blood transfusions, hydroxyurea. Each decision was made in conversation with my healthcare team, and weighing benefits against side effects and how they fit into my daily life. Quite frankly, hydroxyurea has been one of the consistent conversations that I've had over time because you have to take it every day, and that's something that I always make sure to have that conversation with them consistently. Honest dialogue. Fear of judgment, as I've mentioned before, has always kept many patients quiet, and I'm going to speak anecdotally. From my perspective, early on, I hesitated to ask questions because I was not comfortable. I wasn't confident in myself to be able to say, hey, this is what is going on. And a lot of times, I want to kind of be very transparent. A lot of the times, individuals with sickle cell, the healthcare team is the first point of contact. A lot of times, we don't even tend to talk in depth with our families often, right? So having that space with my healthcare professionals has really, really helped me be more confident in advocating for myself. And with the conversations I have with my nurses and doctors and nurse practitioners has given me so much strength and so much empowerment to be able to speak to a crowd like you guys today. And that they played a huge, huge role. They played a huge, huge role. Thank you. They played a massive role in my confidence, right? And I cannot thank them enough. So, building rapport. allowing patients to question, ask why, why this treatment, why this, why that, giving them that opportunity, giving them the table to speak and understand as to what treatments are being provided to them is very important, because then they're able to now go outside and tell their moms or dads or brothers or friends that this is what's going on, this is how I'm handling it, and give them that strength, that confidence to go out there in the world and not be ashamed of what they were born with, essentially. Shared decisions. Patients and providers are equal partners, and not just instructions and compliance. When I'm included in a decision, I understand it. When I'm able to question, I understand things better. I'm naturally a curious person, so I don't want. Sometimes it could be a case wherever you're talking to a healthcare professional, there's naturally a power dynamic, right? You feel this individual knows exactly what they're talking about. I'm just going to take it as law, but that's not the case. They're human beings too. You should be confident enough to ask them questions, right? Ask them, what am I taking? When should I take it? Why am I taking it? Be able to have that dialogue with your healthcare professionals, because then you feel more empowered about something that you, again, were born with, right? It's not something that it's an optional thing, right? You're living with it. And that's where the trust comes in. Healthcare professionals are able to trust the patients because they see the patients as being proactive, and the patients are able to trust the healthcare professionals because the healthcare professionals are answering the questions. There's nothing being kept a secret. And then my main takeaways that I want everybody to leave here with today is the table should be open always, right? A patient, at the end of the day, is an individual with a lot of questions and a lot of fears. And again, I'm going to speak from my perspective. Back then, especially when I was much younger, I had a lot of insecurities about sickle cell, right? And having those conversations and the little startup conversations I had with my nurses, and then building up to my doctors, and then building up to my nurse practitioners, really helped me understand that, okay, this is really nothing to be ashamed about, right? Only starting last year, I really got that confidence working with SCAGO and talking to people and really understanding, hey, there's other people like myself. And a lot of the experiences that I've faced is not unique to me. Every other person too living with this disease has also faced the same things. So with healthcare professionals, please, you guys might as well be our best friends, right? A lot of times when I talk to my nurse practitioners, it's never really more than, hey, how are you doing? Have you been taking your meds? Yeah. How was your day? We have those type of conversations. We're friends, right? So we have to have that floor. The door has to be open to be able to have that back and forth. And then sometimes you actually talk about, sickle cell, and, it should never be the top, I guess, thing in our minds. It's just the conversation we have, right? So that's the biggest thing. Build rapport early, few extra minutes of real conversation, and then it earns the trust of everybody. And I really appreciate SCAGO for the opportunity. And again, like I said, 5 years ago, I would not be doing this. I'd be way too scared. Kind of scared now, but here we are. Thank you guys so much.
So thank you so much for those presentations. Those were wonderful. Does anyone have any questions?
Dr. Johnson, the iron concern that's there, is that only for someone that's taking blood transfusion, or also having iron intake from daily food? And if it's in regards to the transfusion, I think I have personally had about 4 in my lifetime. Should I also get checked for the iron? And then the third part to that, if I'm going to the hospital for crisis, are they not already checking that?
Okay. That last question, I'm sorry.
So my concern is I've had, I think, about 4 transfusions in my life that I can recall. May have been more, but I can recall 4 for sure. Would the hospital not have checked at some point my iron intake, whether or not there's an issue? So I'm just wondering whether or not I have to literally ask for someone to check it, or whether they would have checked it, knowing that I've had transfusions in the past?
Sure. So I will take each one independently. So the iron you get in your diet is more than enough iron for your body. So the diet does not contribute to iron overload. Okay, so those two things are independent of one another. Iron overload really is a function of getting introduced a large amount of iron, and the only real way for that to happen is, in fact, through blood transfusions and through your blood, because that's where most of your iron is in your body. So that's that question. The second question was... Okay. So I am from the US, so I am not 100% sure how things are in Canada. I will say this, from anecdotal and talking to people. Most of the time, so you said relative to the number of blood transfusions, if you've had under 10 and you're fairly certain you've had under 10, it's not mission critical to get your iron level checked. However, I would suggest everybody who has sickle cell disease to get some sort of baseline level. So while it is not mission critical, I would not say go out, you'd have to necessarily do it today. It's the hematologist that you'd have to talk to as it pertains to getting those tests done. At least I can only speak as it pertains to the US system. When you're in the hospital, their purview is not checking your iron. All right, they're going to give you a blood transfusion regardless. If they believe it's medically necessary, they will give you a blood transfusion. It is supposed to be communicated in some way, shape, or form, whether it be through medical records or verbally or however, for the hematologist to be aware of any blood transfusions that you've gotten in the hospital. I, again, don't know how it works in Canada, but in US, that's the way it's supposed to happen. It doesn't. Therefore, it is important for people to have an independent understanding of about how many transfusions they've had. And again, 10 is really the point where I would suggest, since it's between 10 and 20, where you get your iron checked. And again, you should have a baseline understanding of what that looks like, and then work off of that baseline relative to the amount of transfusions you've had. But there's no, again, unless you're getting transfused, your iron level isn't going up significantly where it becomes an issue.
Yeah, and this is a question for Dr. Klaassen. How much does the gene therapy cost? And my second question comes out of that is, are there other blood disorders that are indeed paid for and covered by OHIP?
Great question. So I think the number that's always been thrown around was $2 million that's one for one infusion. So it's actually very expensive. The price is hopefully coming down, and for one infusion, yes. Which is why the government's a bit worried about the cost. And the Canadian, the CDA basically said that if you could cut that price down in half, and I don't know what their half meant, so I think, is that $1 million or $500,000, something like that? It would, the finances make sense. So I think they said $2 million, no way, we can't afford that. When it gets to $1 million, a bone marrow transplant, for instance, costs about $500,000. So if you're getting it close to the cost of, we've accepted the cost of a bone marrow transplant. So if we're getting it close to the cost of a bone marrow transplant, then I think that's reasonable. And sorry, the second question was? Yeah, so the one that I'm involved with is hemophilia. They're doing gene therapy for hemophilia, and they've actually started doing it. So first one was done in London within the last 6 months. So they've actually done gene therapy for hemophilia patients. So it's actually happened. So and they did agree. So obviously they agreed to fund it. So there is a precedent.
What's the cost of that?
I can't tell you exactly, but again, it's about $1 million. All these things seem to be the $1 to $2 million range, is the way it works.
Thank you. Mine actually would be a follow-up because that's the first question I had regarding the iron, and actually both of you probably. So my question was, I understood that yes, for people who receive regular transfusion, but also the one acute, you have a crisis and you receive one. sickle cell patients has regular examination that they do, and sometimes the MRI and all that are performed to make sure that there's no whatever, your brain and everything is looked up. So I wanted to know, among those tests, can or can it be also that they look at the iron at that moment? So my question is it already something that has been looked up through those tests, or can it be? I don't know, yeah.
I can, yeah, since I'm in the Canadian system, I can let you know. It's a fairly routine thing to check ferritin. I certainly routinely check ferritin in our patients, especially ones who've had any transfusion. We'll check a ferritin because it's a pretty simple test to do. The problem in sickle cell disease is because there's a bit of underlying inflammation, ferritin can be, it's not as reliable. It can be what we call falsely elevated, just because of sickle cell. So it's a little bit trickier. So if you really want to know of iron overload, and if you've had more than 10 transfusions, I totally agree, then the better test would be the liver iron, the MRI with the liver iron test. But we certainly can do the ferritin, and if it's low, it's helpful. If it's high, you never know if it's, what the cause is.
No, I mean, yes. So the other thing I'll say as it pertains to that is that you should be getting liver iron tests anyway. And it is, so far as MRI is concerned, they are separate MRIs. So just because you got an MRI for a stroke, prevention and for neurological issues, it's a separate one that would be done for the liver, and again, a separate one that is done for cardiac. I will say that they're working on a way potentially integrating MRI for the endocrine system, specifically to associate with a cardiac MRI, since sometimes if you can do it well, you can pick both of those things up on the single. That's still people are still working on that process and seeing if it's actually a doable, scalable thing, but each one is independent of one another.
My question is addressed to Dr. Klaassen. As part of addressing misconceptions in a context where these abound, I'm talking about Ghana, and can you comment on any connection between hydroxyurea and cancer? The situation being that recently came out on a platform. So I'm with the Sickle Center for Global Child Health, and we have a project in Ghana. And the healthcare team comes with this situation where a caregiver brings their child to the hospital, having defaulted on hydroxyurea treatment for about 3 years. And when they probed, they got to know that the woman understood, or the woman said they were informed that hydroxyurea, is for cancer patients. And so that's why they didn't want to take the medication. So in such a context, as a caregiver, what will you...
Yeah, no, that's great. And that's certainly... So hydroxyurea originally was used as a treatment for certain types of blood cancers. And so that's kind of why I got this label as chemotherapy. And in some pharmacies still, you go to the pharmacy says, oh, this is chemotherapy. You have to wear gloves when you're touching. And they kind of make a big deal out of it. We're trying to downplay that. But it's now, and actually, one of the problems is in Canada, it's not actually approved for sickle cell disease, which is very annoying. It's approved for cancer. So if you look it up, hydroxyurea in Canada, it's approved for cancer, but it's not approved for sickle cell disease. And I'll tell you the reason why. The reason why is because it's such an old drug, there's no, the way Health Canada works is that an industry partner has to apply for an indication. Since it's so old, there's nobody around to make money out of it, so they don't actually do the paperwork. So this is why it's never happened in Canada. It's a flawed system in Canada. So that's why if you look it up, it'll say it's a cancer drug, but it's actually not really used very much for cancer anymore. It's really primarily used for sickle cell disease. But there's very good studies that looked at, is there an increased risk of cancer on hydroxyurea versus not on hydroxyurea? And there's excellent studies showing that there's no increased risk of cancer on hydroxyurea compared to not being on hydroxyurea. The one thing that just to be aware of is that unfortunately sickle cell disease does have a slightly higher risk of cancer overall because your bone marrow is working so hard to make these red blood cells. There is a slightly higher risk of getting blood cancers if you have sickle cell disease. So I think that's where some of the confusion may have happened in the past.
My question is for Daniel. So we've talked a lot about therapies and diagnostics and technology innovations in sickle cell disease. As a warrior living with sickle cell disease, what would you say are the three biggest things that we're missing when we think about developing therapies, diagnostics, and innovations? What do you wish we would focus on more to better improve your life?
I think one of the biggest things I think that a lot of focus should be on, well, not a lot, but it plays a huge role, is the mental aspect. So everything you've mentioned has been pretty physical, but just as physical sickle cell is, it is equal parts mental, right? I feel like that's one of the biggest things that so far my healthcare experience has been amazing. I'm very extremely grateful for the people that I've had around me to grow in my healthcare journey here in Canada, especially with everything that you've been doing as well. Has been very interesting to listen to. It's very brand new to me as well. It's been amazing. But I think one of the biggest things overall is mental. Because that's another part of it that I feel like a lot of people tend to forget about sometimes, is, like you mentioned too, it's not until a crisis happens that people should then start saying, oh, something has gone wrong. But then it's not also after the crisis happens, then, okay, the crisis is done, okay, you're good. But a lot of times for us, it typically is the mental aspect of it. When is the pain gonna happen again? Is the pain gonna happen? Can I go out? Is this gonna happen, you know? So I think that's a big part of what I've been focusing on myself, is trying to find people to talk to, you know, go into communities like SCAGO, for example. But yeah, I hope that answered your question. Yeah.
Yeah, and I have, as a moderator, I want to have a last question with you as well, Daniel. So, as I said, I have sickle cell disease myself. I've been taking hydroxyurea for over 30 years.
Wow.
Are you on hydroxyurea? And if you don't take it, then why not?
Oh, I am on Hydroxyurea.
Okay.
Yeah. Honestly, I think the past 2 years now, I'll be very transparent too. I have been on and off, especially as when I was much younger. It'd be very hard to keep track. But again, with conversations with my healthcare professionals, asking questions, making sure I know how important it is, I've been pretty steadfast on it for 2 years now. So yeah, I am on Hydroxyurea.
Wonderful. We'd like to thank the panel for that wonderful discussion. We are at time. If you still have a question, you can ask the panelist member during the break. But thank you so much for participation. We're going to take about a 15-minute break, and then we'll be back with the next session. Thank you.